Hi everyone, welcome back to another session Learn Anatomy Online. So last week we started off with the cranial nerves. We looked at the nerve roots and the start point of the brachial plexus, and we looked at dermatomes and cutaneous fields, and started to look at what those nerves do for the upper arm. Just want to make sure that the comments are working, so I'll just pop a message in here. If you have any questions whilst we're live, then just pop a question in the comment section, and I'll answer those. If you're part of the Learn Anatomy Online Facebook group, then and you're watching this on catch up, then you can post a question whenever you like in that group. Good morning, it is working. That's good. Morning, Tris. Good to see you there, mate. Right then, let's get going. Let's get the right PowerPoint here. Okay, so this is kind of where we left off, and just wanted to recap some of this. So we looked at the individual nerve roots, and then how they started to come together to form the plexus that goes down the arm. And one of the things we looked at was the sensory part of the nerve and the motor part of the nerve, and there are different names given to the way that we receive information from the skin. So if you touch the skin and there's a loss of sensation, there could be a couple of different reasons for it. Well, a few different reasons, but we looked at two last week, and one of them was dermatomes, and one of them was a cutaneous field. So I'm just going to quickly recap those for you. So dermatomes, and again, there's a detailed description on this from last time. So I am going to skim over this. So just to let you know, so if you're thinking, blimey, I've no idea what you're talking about, then have a look at the previous episode, which is 192, and we go into a lot more detail on that one. So if we split up the word, as in a lot of anatomy, we split up dermatome into the two kind of sections. So we've got derma, which means skin, and then tome, which means a section. So there will be a specific section of skin that is innervated by a specific, in this case, a specific nerve root. So you might have heard of like C5, C6, C7, and again, we went over those last week. So if there's an injury to a specific nerve root, so say you have some kind of lesion at C6, there will be a specific area of skin. When I say specific, it's there's a lot of crossover, but there is a general area of skin that will be affected if the C6 nerve root has a problem. Okay. And if you have a patient in or a client in, and they have numbness or pins and needles kind of feeling, loss of sensation in that particular region, then it could be something to do with their nerve root. That's the issue. So you would need to do a neurological exam, and then based on that neurological exam, you then refer them for further tests. There are, however, some other reasons why you may have pins and needles, tingling, numbness, and we're going to explore another one of those today as well. Okay, so it's not all clear cut, unfortunately. So a dermatome is an area of skin that is innervated by a single spinal cord level. So that single nerve root level, that's what a dermatome does. And they may be distributed to their target region by more than one peripheral nerve. So what we mean by that is you've got several peripheral nerves, especially we're focusing on the arm. For example, the median nerve, the ulnar nerve, the radial nerve, musculocutaneous nerve, the axillary nerve. So those are the nerves that supply the motor and sensation for the arm. And the contribution to sensation for a particular region in the arm may come from more than one of those nerves. So it might be shared. Okay, so the nerve root, there's only one route that comes out of there. So if there's a problem there, then it will knock out the whole line basically. Okay, and that particular nerve root, there may be contributions of sensation coming from several different nerves. Okay, so I put it like this, like a roadmap. Because I live in Birmingham, I chose Birmingham to London. Could have chosen a better destination actually. So we've got Birmingham down to London. So we've got sensation in the skin. Okay, so same start point in the skin, and then there are different routes to get to the nerve route, which is London. Okay, so the end point, if you like, because if you remember, it's kind of flipped because we've got sensation in the skin and then the information going towards the neck. Because we always think about the neck sending out impulses towards the rest of the body, but obviously that's the motor side. But if you've got sensation in the skin, which is in Birmingham, so say for example, you touch something hot, okay, and it's, or something touches your skin that is hot or sharp, then that's picked up here, and then the sensation then travels to the nerve root, and it could travel via different peripheral nerves. So it could be muscular cutaneous, it could be medial, or whatever it is. The end point is the same, so the nerve root is the same for both of these pathways, for both of these nerves, but there's a different route to get there. So we've got this route here, we've got this route here. Okay, and again, we covered this last week, so I'm just going to skim over. Then we have something called cutaneous nerves. This is an area of skin sensation supplied by one peripheral nerve. And hopefully, I think I've got it on this presentation. Let's have a look. Let me go for it. No, I didn't put it on this one. That's a shame. So yeah, basically you've got these offshoots of the peripheral nerve that supply the skin. So for example, the radial nerve, as that travels down the arm to the back of the hand, it will have motor sensation to various muscles that it supplies, but there will also be an offshoot of a cutaneous nerve that receives information from the skin or the joint. Okay, so if it's a problem with the elbow, then that the elbow joint itself, one of the peripheral nerves that supplies the sensation for that joint is the radial nerve. It also supplies sensation for the back of the arm and down into the back of the hand. Okay, but it's shared in different places with other nerves as well. So the radial nerve will have points along its pathway that where it receives information from the skin. Okay, so if we have a look at this, we have got a nerve root C6, and these are the dermatomes. Let me just get rid of that. So if you have a problem here, and you've got two different nerves that pass down to supply the skin in this area, it will knock out the whole area. So for example, well, depending on which dermatome map you look at, so C6 can be up to the shoulder as well. Okay, on some dermatome maps, there's a lot of crossover. So, for example, if you have your thumb and this area of your forearm where there's a loss of sensation, then it could be C6 that's affected, and it's just knocked out this whole area. Okay, these are the cutaneous fields, which are supplied by specific peripheral nerves, and if you have a problem with the nerve root, it still knocks out the whole lot. Okay. So if we have a problem up here, no matter whether it's a cutaneous field, so a specific section of skin, or a whole region, both of them will be knocked out. So if we go for some, all, or none, it's all of it will be knocked out. Okay, so you'll have an odd sensation throughout the whole dermatome. If there is a problem with one specific nerve, then because the sensation is received from various different nerves along the dermatome, you will only lose sensation in a cutaneous field. Okay, so you'll still be able to feel this area here, but this area will disappear. Okay, so for example, that's this bit here. So the peripheral nerve, so this nerve here, only supplies that section of skin. Okay, but in combination, the nerve root, it supplies both. Hopefully that makes sense. So if you've got this nerve here and there's a problem with that nerve, it's just going to knock out that bit of skin. But because this nerve is still functioning, then you'll still be able to feel that area there. So even though they share the same nerve root, you will only lose sensation in a specific cutaneous field. So for example, if you have an injury to the radial nerve, I've used that one as an example again, and a Saturday night palsy. So the radial nerve wraps around the back of the humerus, and if you put your arm on the back of a chair and it squashes that nerve, then you'll lose sensation in certain areas of your forearm, but not all of it. Okay, whichever area the radial nerve supplies, that's the bit you'll lose, but all of the other peripheral nerves will be able to receive information still. Okay, so this one, is it some, is it all, or is it none? It's some. Okay, so if you have a nerve root issue, it will knock out the whole lot. If it's just a peripheral nerve issue, then it will be a specific section of the skin. Okay, so these are cutaneous fields supplied by one peripheral nerve. This is a dermatome, which is supplied by several. Okay, hopefully that makes sense. So just move me here. So yeah, if you injure a nerve root, you lose sensation in the entire dermatome. If you injure a peripheral nerve, you lose sensation in just the cutaneous field. Okay, so that will help with sensation checks. Hopefully I've just answered that. Could you give an example injury in both cases? So does it come from neck or elbow? Yeah, so for example, if it's like C6 that you've injured in your neck, it will knock out this whole C6 region. Okay, if it's the radial nerve that's a problem, then you'll knock out that section there, and that still has contributions to C6. Okay, so C5, C6, but because the nerve root isn't compromised, if you've just affected the radial nerve, you'll still be able to feel this, you'll still be able to feel this, because that's contributions from the musculocutaneous nerve, that one's contributions from the median nerve. So you'll still be able to feel that area there and there, but this area here will be a bit sketchy. Okay, so if it's just the radial nerve, then it'll be that bit, as an example, and there. But if it's C6, it will be all of that. Okay, down into the thumb as well, because see the median nerve will be trying to send information from the thumb up to the neck, but if there's a blockage at the neck, nothing's getting through. And the same with this area here, nothing's getting through, nothing's getting through. Okay, so yeah, if it's a whole area, then it's more likely to be nerve root. If it's a specific patch, it's more likely to be cutaneous nerve. Okay, but either way, they still need a neuro assessment to see what's going on. So dermatome, our start point in the skin is up in Birmingham, and we had these different routes to get to the nerve root, but there's a crash in London, so nothing can get through. Okay, so car crash in London, which is the nerve route, nothing is getting to the destination, so nothing will reach the king. Okay, nothing will get there. And then if we have a car crash on a specific peripheral nerve, it will only affect that nerve, it won't affect the other one. So you can still get sensation received in London, but not via this route. So whichever area of skin this particular nerve supplies, the nerve root won't be able to receive the information. Again, hopefully that makes sense. Right. This is kind of why it all happens the way it does. And I think Penny asked a question last time about why this, why that. There's a lot of stuff we don't know why. We know how, but we don't necessarily know why it occurs. Depends on your beliefs, I think. Okay, so nerve root is cervical spine start. Yes, that's right. Yeah. So C6 is cervical spine number 6. Okay, so that where the nerve comes out, they're all numbered, and number C6, that's where the problem will be if it's that part of your arm and down into the thumb. Okay. Okay, so this is that how it all occurs. So we've got an embryo here, and there are these things on the back of the embryo called somites, and those somites start to differentiate and form structures as you develop. Okay, so let's just go to this one. This is a busy slide, apologies, but the areas that we're interested in are down here. Okay, so don't worry about anything else. We're just focusing on this area here. So we've got the neural tube at the top here, which will eventually become the spinal cord. And then there are different layers of tissue that then split off and form structures as we develop as an embryo. So if we have a look down here, we've got yes, we've got the mesoderm layer. So we've got the somite splits into dermomyotome, so with the skin and the muscles. And then down here we've got myotome, which is skeletal muscle, and dermatome, which is the skin, and then skeletal muscle. Okay, so we will have areas of the body that are developing in that somite where they're linked. Okay, so the nerve supply to a muscle will start in like a little sausage, and then as we develop our arms and our legs, the muscles will start to grow, and the bones will start to grow, and the nerves that are attached to those muscles and the areas of skin that are growing as well, those nerves will get stretched along that pathway, and that is how we get the formation of our nerves within our body. Okay, when you develop, you'll have several nerves that are supplying a specific muscle. You'll have several nerves that are supplying a specific part of the skin. But what will happen is the nerve impulses that travel down those pathways, there will be certain nerve pathways that will be a stronger impulse, okay, and that will become the dominant nerve. And then the other nerves that were supplying that region initially, they'll start to die away, they'll start to atrophy because they're not being used. So, and that is how we develop our nerve network, and how everybody is slightly different, okay, because there will be some people who don't develop certain areas. There'll be some people where there'll be increased amount of nerve in a particular area. So I'll give you an example of in the upper body, in terms of skeletal muscle. There is a condition, this is the one that I studied when I did my clinical anatomy, it's called Poland syndrome. And there's a specific point in embryology where the pectoralis major or minor muscle doesn't develop. It just skips that step. But then the other steps, the rest of the arm is fine. It's just that specific bit just doesn't develop. Okay, but usually it all develops in sequence. But for whatever reason, and we don't really understand it still, that it skips that particular section, and you just don't develop a pec minor and sometimes a pec major. Okay, so there'll be other times where you'll develop more muscles. So for example, with a peroneus tertius, some people don't have them, some people do, and it will be from the developmental stages in embryology. Okay, so this region here is the one that we're interested in. But obviously, if I mean, like I said before, embryology is just a whole year of this, all on its own. So this is the neural tube. These are the structures that will eventually form the vertebra, and then there's the layer of tissue cells that will form the muscle layer, and this is the layer of cells that will form the skin. Okay, so we've got dermatomal layer, myotome layer. So remember, tome is a section, so we've got muscle section, dermatome, skin section. So, and they will be dragged out down the arms as we develop and as we grow. Okay. Cool. So this is a nice visual of that. We've got the neural tube here. So it starts off but like a line. We've got the developing vertebra, and then the nerve roots will start to creep out because they're attached to the muscles, and they'll get dragged with the muscles as they grow. And then obviously they'll go down into the hand or the forearm or wherever it is. But literally those nerves will get pulled as your arms develop. Right. So that is why we have sectional dermatomes. And if you put your arms out to your side, so in a T shape, okay, then the dermatomes follow a line. So that area of skin there is formed from C4. This area of skin here is from C5. There's C6, which is down to the thumb. C7, middle finger. C8, little finger. Okay, so you can see where all those pictures that we've seen before of the dermatomes, this is where it comes from. But obviously we don't walk around with our arms out to the side. We walk around with our arms down by our sides. So that's why it looks all twisted and as if the nerve roots are going all over the place. And it's like, why is C6 there and then C8 is on this side? But if you put your arms out to the side, it makes sense because, and whether you can see me, they all go in a line. Okay, so if your arm's out to the side, the skin is all in a line and it's all exactly the same as this picture here. But obviously as we develop, our arms will grow and then they'll twist. So that's why it looks a bit weird. Same with the legs. Yeah, so if you have a look at the legs, there's L1, there's L2, contribution L3. But obviously our legs don't just go out to the side. As we grow, they come down and then they rotate. So that's why the dermatomes look twisted. Yeah, and it's confusing. But if you imagine someone doing the splits and then someone with their arms out, like in gymnastics, that will be the dermatomes. Okay, so that's where they come from. And we talked about this last time, the variations in skin maps, but these points, these specific points are very, very reliable. Okay, so if you wanted to check C6, so the nerve root C6 and the sensation, then you touch the thumb, and that is the most accurate point to detect sensation in C6. Okay, C6 supplies all of this area here, but there's a lot of crossover. But that point there is more specifically C6 rather than anything else. Okay. Hopefully that makes sense. This is a really good picture, by the way, to have in your clinic. So if you are doing neurological testing, then you can test those points. Okay, right. We're going to move on to that on a different session. So let's have a look at this next one. Cool. So that's a recap last week. And I've added in a bit of embryology as well to show the how this happens. Again, we don't really understand why it develops the way it does. It was just evolution. Obviously, that's an evolutionary beneficial way of developing. Okay, because we're all here now. Yeah, that's the how it happens. So we're going to have a look at the blood supply now for the neck region, and there's a couple of important areas. Just get rid of that for me. There we go. Okay, so this you might have heard of before. Might have heard of the carotid artery. Yeah, so it's the kind of pulse you take in the neck. So if you've ever done first aid and well, we don't do pulses anymore, but if you remember like 20 years ago when we used to take pulses, you could take a pulse in the neck, and that will be the carotid artery that you'd be feeling just there. And the carotid artery splits into two sections. So we've got an external carotid artery that supplies the kind of cheek and the jaw. And then we've got the internal carotid that goes all the way up into the brain. Okay, so we've got two major areas. So the carotid artery is split into external and internal carotid arteries. So let's have a look at that. This one, I'll just pause that there. Just to let you know, I mean, looking at muscles, looking at joints, once you get used to it, it's all okay. This is kind of visceral stuff, blood supply stuff, and sometimes it does turn your stomach a little bit. So just a warning before you watch it. Okay, here we go. Straight into it. So there's sternocleidomastoid removed, and that you can see the vessels behind it. Infrahyoids removed, jugular vein removed as well. There's your clavicle. And then if we look kind of top down from here, so the first rib is underneath here. Yeah, you can't see it because of the structures. But we're looking at the kind of right down into the top of the neck. And we can see a couple of tube networks, so one there, which are really, really thick. And these are the start of your vessels that go up through the neck and then up into the brain. The heart is obviously not far from here. And if you think of the arch of the aorta when we looked at the heart a few months ago, these vessels come straight off the heart. Okay, so on that arch of the aorta, that's where these will come from. So let's just follow this through. So there's your anterior scalene. You can see the nerve network as well, trachea, thyroid. Common carotid just there. Let me just pause that there. So that's your common carotid just there. So that's the one we've just seen on that picture. And then that one there, that's your subclavian artery. So subclavian means underneath the clavicle, and that's where it goes. So if we have a look, remember this was the anterior scalene. There's your brachial plexus, and then there's the subclavian, and it's coming through the same gap that the brachial plexus comes through. Remember I was saying that there's some other reasons why you might lose sensation in your hand. So we've got the nerve network. So we've looked at C6, C7, C8, T1, but supplying various sections of the skin in your hand. So if there's a specific finger or a specific thumb that has lost sensation, then we go, right, if you've lost sensation on the tip of your thumb, but nothing else has been affected, it's more likely to be a C6 nerve root problem, okay, if the rest of the skin is okay, because that is the area where there's little to no crossover other than C6, okay? If you lose sensation to your whole hand, so the whole hand starts going pins and needle tingling, that's less likely to be a nerve root issue unless you have multiple injuries in the neck. It's more likely to be a blood supply problem, because when you cut off the blood supply, so if you lie on your arm at night and you cut off the blood supply to your hand goes numb and your arm goes numb. And then when you kind of shake it off a little bit, the sensation comes back again. So if you've lost sensation to the whole hand, it's more likely to be a blood supply issue. And if we think about this area here, that's the blood supply for the whole arm. And you can have something called thoracic outlet syndrome, where it's either a neurogenic compression, so it's coming from the nerves, or it's a vascular compression, so coming from the blood supply, that is causing the loss of sensation in your hand. So if it's certain fingers, it's more likely to be the nerve. If it's the whole hand, but when it goes, you kind of shake it, and after about 30 seconds, a minute, it comes back, it's more likely to be the blood supply. Okay, so just like lying on your arm, As soon as you release it and turn over in bed and you give it a shake, then the blood comes back to the hand, and then you lose that the sensation of pins and needles. It comes back to normal. But if you've got a nerve root compression, doesn't matter how much you shake it, that's not coming back. Okay, I had that once in my thumb. I can't remember which one it was, thankfully, because it was horrendous. Had it for about 3 months after I was doing a really heavy deadlift, and I just felt something pull in my neck, and then immediately my thumb, I think it was this one, my thumb went completely numb, and I couldn't feel it for about 3 months, and then eventually it started to come back. So you can get, and that's mimicking what in rugby or contact sports, where you get something called a stinger, where you get a quick stretch of a nerve, and then you lose sensation in that nerve. Okay, and it's neuropraxia. So yeah, it can either be a compression or a pull, and yeah, and it was immediate, and it was just so weird because I could kind of feel my thumb, but it was just a really, really odd sensation. But it came back eventually, thankfully. So this region here, I mean, you can see how tightly packed it is, either affecting the nerves or the blood supply, and those nerves and the blood supply both go under the collarbone, so the clavicle, and then as they travel down their arm, down the arm, there can be several compression points that can cause compression of those structures, which will give you those symptoms. So either a thoracic outlet syndrome, or some kind of nerve root compression, or peripheral nerve compression. Okay, so hopefully it starts making some symptoms make sense. So both structures, subclavian and common carotid, come through that area there. Okay, so if you have a look here, there's the arch of the aorta just there. We've got the brachiocephalic branch, which is on the right side of the body. On the left side of the body, it's a bit different, and we did cover this when we looked at the heart and the blood vessels of the thoracics. So where the arch of the aorta is, on the left side of the body, you've got two separate arteries, one for the subclavian, which is just there, so that will go off down the arm, and then one for the carotid, which will go straight up to the neck. But on the right hand side, it's different to that. So we've got brachiocephalic here, and then there'll be another branch of carotid on the right side going up. So it doesn't come off of the arch of the aorta, it comes off this offshoot just here. And then we've got subclavian, which will come off that and then down the arm. So left side, you've got arch of the aorta, two separate vessels, so carotid and subclavian. On the right side, you've still got two vessels coming off, but they've initially there's another branch coming off of the aorta before they split, before they bifurcate. Okay, so let's have a look at that through. So yeah, there's the carotid. So you can see the difference there, brachiocephalic and then the carotid, and there's a bifurcation just as it splits. So anterior scalene just here. There's your subclavian. We've got some more vessels coming off that as well here. We'll have a look at those in a sec. So there's your anterior scalene muscle. There's the subclavian artery just there. There's the nerves. Okay, so that goes underneath the clavicle, underneath your collarbone. There's your carotid just there. Okay, so we've got internal thoracic, so that will go down into your into the rib cage area. Thyrocervical trunk, so that's going off towards the thyroid. I'll just pause this at specific times. There we go. So this one will be important for later. So there's your subclavian, and there's a branch coming off here, which is called the vertebral artery. Okay, and that does exactly what it says on the tin. It travels up through your cervical vertebra. And if you remember when we did the bones and the of the cervical region, they had holes in the side of them where they travelled up, and that's where this vertebral artery will go, and that's going straight up to the brain as well. And then there's your carotid. So there's two separate arteries This one's coming off of the brachiocephalic. Okay, so it's got its own supply. This one is coming off that subclavian. Okay, and then up there, and it'll be mimicked on the other side of the body as well, although rather than coming off that brachiocephalic trunk, it will just come off the arch of the aorta. So it's exactly the same design at this point here. Okay, it's just got a different start point, that's all. So there's the vertebral artery there, there's your carotid. So that's your common carotid before it splits, and there's the split, look, just there. So it splits into two arteries, so we call that a bifurcation. And remember, but the image that you saw, one branch went off to supply the kind of side of the face, and the other one went deep and then went up into the head to supply up into the brain. And there we go. So there's your mandible, so the side of the jaw. There's your external carotid, internal carotid just there. So we've got the parotid glands, salivary glands, and then with those removed, you can see the pathway again of those nerves, of those blood vessels. So that area there, we've got a baroreceptor, which means a pressure sensor. So this senses your blood pressure. Okay, there's what's called the carotid sinus, which is it's an enlarged area, and you can see it there. There's like a swelling around it. So this is the baroreceptor site where blood pressure changes are detected. Okay, so that's a really important area. So this is why we get funny about massaging around someone's neck, because if you push on that, you will affect their blood pressure and they can faint. Okay, cool. What time are we at? Perfect, I think. So that's that, and the start of it as well. So what we're going to do, we're going to have a look at these different branches and where they go to. So we've seen the split, we've seen where that carotid sinus is around this area here. There's also a chemoreceptor site in that area as well, so it detects chemical changes in the blood as well. So baroreceptor, if you think about a barometer, that's why I had the picture of the barometer on there, that detects pressure changes. And remember my granddad having a barometer on the wall, looking at the pressure changes and seeing where the weather was going to turn. You could tell he was a naval man. Cool, right, let's have a look at, just pause that there. Let's have a look at the internal carotid first. So this is going up into the head. Here we go. So there's your carotid sinus, and that is the point that Spock used for his Vulcan death grip. Okay, yeah, there you go. Perfect timing. So that carotid sinus area there, if you get it in the right spot, then you will knock someone out. Okay, it's there are lots of these points that are used in martial arts so for example, the radial nerve that I talked about before, where it's really superficial, if you get punched in the back of the arm, it then knocks out all of these muscles, so you can't make a fist, you can't bring your arm up. So there's some points that people learn when they're doing martial arts to try and target, so that you knock certain nerves or blood supply out. So here's the split, here's the bifurcation, there's the carotid sinus just there, and we'll follow this through. So internal carotid, there's your digastric when we looked at the hyoid bones, styloid process and the muscles, and then there it is there, look. Okay, so that's your internal carotid. So we'll look at it going into the base of the skull. The jugular vein would be there. There's a little opening for the jugular vein. So there's your styloid, and then there's the hole for the carotid, internal carotid artery. So it's right at the base of the skull. And then if we flip the skull over, That's where it comes through and finishes here. Okay, so we've got the at the base of the skull, there it is coming through there. So that's the internal carotid. And there's it's where the brain sits. Okay, so this is feeding the kind of base of the brain, where the brain stem is. So it turns back on itself, so you can see the kind of cut end of it there, and then it goes underneath this section here, and then comes out there. So we've got that turn in it. There's the optic canal for the eyes. I've just been editing the cranial nerve video, so I'll release those shortly. There's the optic nerve, and then there's the internal carotid just there. So it takes a couple of little little deviations in its path. So it's not just straight up, but it wraps around different structures. So it's really well protected in the skull, and then it's getting towards the brainstem. I've put this picture on here because this is probably one of the cleanest ways to learn the pathway of vessels and nerves. It's from the book Instant Anatomy. So that's the ophthalmic branch just there, which is that area just there, which we've just seen on the video. And this vessel here, so there's the ophthalmic artery, which comes off of the internal carotid. So this area here links up with some other vessels that we'll see in a second. Okay, so that this area here forward to the eye and the forehead is over this way. And then there's the vessels coming through. Okay, that bit there, the optic chiasm, just pop that there. So that these are the nerve supply to the eyeballs. Okay, and so they'll go off that fascia there. Underneath there, there'll be an optic canal where the optic nerve will go through to the back of your eye. Okay, so it's over this way here. But you can see the relationship with the blood supply. Yeah, so rich blood supply. Remember, this is coming just off the arch of the aorta straight into the head. So it's oxygen-rich blood to supply this very important region. Perfect. Okay, what time are we at? Done for today, I think. Okay, I will go over this again next week because it's there's a lot. Okay, so we have looked at the start of the blood supply to the head and the neck, in particular the carotid artery, where it's different on the right side to the left. And then we've looked at where things split, and so we've got a carotid artery and then a subclavian artery, and then we followed that carotid artery up where it splits again, so it bifurcates, and then we've got part of the artery that will go into the cheek, so that's the external part, and then the internal part which will go into the base of the skull, and you've just seen the pathway where it goes up and right into the base of where the brain will be. Okay, so that area we've just seen, the brain will sit on top of that, and next week we'll have a look at the blood supply called the Circle of Willis. That supplies the brain stem, the base of the brain. Okay, and also the start point for the other blood supply for the rest of the head. Okay, yeah, exactly. Very good. Right. So that's it for this week. So we'll do a little recap of what we've done today, next week, and then we'll finish off that blood supply, and then that will be the cervical spine done, and then we'll start to move on to the shoulder. See you next week.